Welcome to another episode of the JASN podcast series. I'm Kurella Tamura, Deputy Editor at JASN for Clinical Science. Friends, today we are going to examine a question that stymied nephrologists for decades: to anticoagulate or not to anticoagulate the patient with atrial fibrillation on dialysis. Is it nobler to suffer through warfarin, to take up arms with DOACs, or to not treat at all? To help us answer these and other burning questions about anticoagulation, we're joined by an expert in the field and lead author of a new study in JASN, Anticoagulation for Patients with Atrial Fibrillation Receiving Dialysis, the SAFE-D trial. Dr. Ziv Harel is a nephrologist and associate professor of medicine at the University of Toronto. Welcome, Dr. Harel.
Thank you. Thanks for having me. I'm excited to be speaking with you today.
We're really excited to have you, and congratulations on this really exciting work. So let's dive right in and set the stage for our listeners. You know, there are some uncertainties in the non-dialysis population about who should receive anticoagulation. But for most of these patients who have an indication for anticoagulation, the choice of therapy is pretty clear for them, isn't it?
Correct. And this is really well established in the non-dialysis population. And that includes individuals with moderate chronic kidney disease. Oral anticoagulation is really the standard of care to prevent stroke and systemic thromboembolism in individuals with atrial fibrillation. And this is based on really years of work and seminal trials that began in the late 80s and early 90s that compared vitamin K antagonists with placebo. And these trials demonstrated that there's a 60 to 70% relative risk reduction with vitamin K antagonists in terms of stroke, in terms of decreasing the risk of stroke. And so that really became the standard of care in terms of treating individuals who have atrial fibrillation. And with the introduction of the DOACs early 2010s, there've also been lots of seminal trials that have found them to be non-inferior to vitamin K antagonists in terms of stroke prevention. And sometimes superior in terms of their bleeding, their tendency to cause less bleeding. So when you look at it in general, we have very robust evidence in the non-dialysis population for oral anticoagulation.
But the balance between the benefits and the risks for the dialysis population isn't as clear, both the choice of whether to anticoagulate patients and then also which anticoagulant to choose. Can you speak a little bit to why that is?
Yeah, you're absolutely right. And it's a little bit more complicated in the dialysis population. We know that as kidney function declines, the risk of stroke increases, and dialysis recipients have about a 5 to 7 annual risk of having a stroke. Additionally, dialysis recipients at baseline have an increased risk of bleeding, and depending on what study you look at, between 7 to 10% of dialysis major bleeding will occur within 7 to 10% of dialysis recipients within the first 3 years of being on that. So there's really that balance between stroke and bleeding. But what's also another factor that we have to take into account is that our patients have a high risk of mortality. And as dialysis recipients have a 10 to 15% annual rate of mortality, which adds a competing risk to that balance there. So you have to really look at all those factors when deciding what to do. And there isn't much clarity right now because these individuals have been excluded from randomized controlled trials.
Yeah, you bring up some really great points. There's also a concern with warfarin, isn't there, about the potential for warfarin to contribute to vascular calcification. And so there's that potential risk to throw into, these decisions as well.
Correct. You're absolutely right. There's the issue of vascular calcification, calciphylaxis, and despite dialysis recipients being in a unit where they have access, pretty much nursing and physicians have access to point of care blood work where they can assess the INR. If you look at observational studies, particularly from the VA, the mean INR and the mean time in the therapeutic range is very low at 42%, which is staggering, especially in a population that has so much access to health care.
Yeah, absolutely. Let's talk a little bit about the sort of the previous evidence, so the previous trials in this area in the dialysis population. There have been some attempts to study this with randomized trials. I think there have been three studies: a renal AF, Axadia, and then Valkyrie. But the evidence is still kind of muddy, isn't it? Can you tell us a little bit about what those studies showed and why interpreting them is challenging?
Absolutely. And I think there are two sort of like overarching questions that we have to look at. One is, whether we should even anticoagulate dialysis recipients with atrial fibrillation. And if we should, then what's the optimal anticoagulant that we should use? And you're absolutely right. There have been three trials that sort of looked at the second question. And, assuming we should anticoagulate these patients, what would be the optimal oral anticoagulant agent? So the Valkyrie study was a study that compared low-dose rivaroxaban, so 10 milligrams of rivaroxaban, to dose-adjusted vitamin K antagonists. And their primary outcome was a composite of stroke and cardiovascular events, both fatal and non-fatal. They looked at secondary bleeding outcomes, but the primary one particularly was stroke and cardiovascular events. So they recruited 132 patients, I believe, and they found that there was a significant decrease in their primary outcome amongst individuals who received rivaroxaban compared to the vitamin K antagonist group. And similarly, there was a significant decrease in major bleeding events in the rivaroxaban group. But what's interesting about this study is they had an extremely high mortality rate of between 60 and 70% in both the rivaroxaban and the vitamin K antagonist group, which really highlights, the fact of that competing risk. So that's one issue that trial brought up. In terms of the renal AF trial, so this was an apixaban versus warfarin, dose-adjusted warfarin trial, and it looked at a composite bleeding outcome of major bleeding and clinically relevant non-major bleeding. I think it was a non-inferiority study as well. And this study was looking to recruit, I believe, 800 and something patients, but it was stopped prematurely because recruitment was an issue, and they were only able to recruit 154 patients. And the issue in terms of outcomes, because this study, didn't recruit its sample size, all the clinical outcome, the study was underpowered to make any assessment of clinical outcomes. But just looking at the information, there were more bleeding events than there were stroke events, particularly in the warfarin group compared to the apixaban group. But again, because of the premature termination of the study and the smaller sample size, we really can't glean anything about the clinical outcomes. The Axadia AFNet-8 trial was a similar design. It looked at a non-inferiority composite bleeding outcome, but instead of looking at dose-adjusted warfarin, they used a lower dose of warfarin, 2.5 milligrams twice daily, and compared it to dose-adjusted vitamin K antagonists. And similar to renal AF, this study also had issues with recruitment, and in the middle of the trial, they had to readjust their sample size calculations and ended up, instead of recruiting about 200 and something, which they originally looked at, they ended up recruiting 97 patients. And again, they didn't find that they didn't meet their non-inferiority outcome. The issue with both of these trial, and I think all of them, is that they were a very short duration, from just under a year to about over a year and a half. So while bleeding outcomes may occur rather quickly and rather early, maybe there wasn't enough time to see stroke outcomes mitigated in any particular way.
I think you brought up some great points. I want to follow up on one of them. At least two of the three trials encountered recruitment challenges. And that raises the question of, whether they were targeting enrollment of the right patients and or whether there was a lack of equipoise among the clinicians whose patients were being approached for this study. And so I want to, kind of dive deeper into some of, your team obviously thought a lot about these issues when you were designing safety. And I wonder if you could sort of share some of your, considerations. First and foremost, why a pilot study instead of, the other trials were non-inferiority trials and they were aimed at efficacy outcomes. So why did your team choose a pilot study design?
Yeah, so doing a large scale trial is a momentous feat, and all the investigators that worked on the previous trials are really great trialists, and I know that they thought long and hard about everything, and we didn't want to dive into doing a large scale trial because of our concern about recruitment. We wanted doing a large scale trial, involves a lot of hard work and labor amongst the trial team. It involves patients have to be recruited, and you're asking them to give up a lot of themselves, and these also cost a lot of money, and we didn't want to waste anybody's time and money doing this. So prior to going and doing a large scale trial, we wanted to do something that was much more smaller and defined, and we wanted to in the end do a pilot study looking to see if it's even practical to do a large scale trial given the limitations of the previous one.
Yeah, let's talk about some of the specific choices around the population and the intervention. So safety enrolled adults who were receiving dialysis and had a history of non-valvular atrial fibrillation who met the CHAD-65 criteria. And patients who were receiving anticoagulation were eligible as long as they didn't have a non-AF indication for anticoagulation. So the population included a mix of new users to anticoagulation potentially and prevalent users. And then they were randomized to apixaban 5 milligrams twice a day or dose-adjusted warfarin targeting an INR of 2 to 3 or no anticoagulation. And the treatment was open label. So I'm wondering if you could speak to some of these design decisions. So I'm thinking about, why did you use CHAD-65? And maybe for some of our listeners who aren't familiar with that, what is CHAD-65? Why did you choose an open label design? And, going back to something you talked about at the beginning, why a placebo arm?
The majority of the majority of sites that enrolled in the study were based out of Canada. And in Canada, in terms of stroke risk scores and stroke risk stratification, we primarily use the CHADS 65 risk score. And that's an adaptation of the CHADS VASC and the CHADS 2 risk score. Basically, what this score is that if you're over 65, you're eligible and have atrial fibrillation, you're eligible to receive oral anticoagulation. But if you're under 65, you would only benefit from receiving oral anticoagulation if you meet one additional stroke risk factor. So those being congestive heart failure, hypertension, diabetes, or a prior history of stroke. And we chose that because of simplicity and just because of familiarity in the Canadian population. Having said that, we did include the CHADS VASC score within our trial, and it's contained within our table 1. the whole issue in terms of risk stratification in dialysis recipients using these risk scores is quite murky in itself. And if you actually look at the ability of these risk scores to discriminate who's going to have a stroke or systemic embolism versus who doesn't, they're not the best discriminators there. The area under the curves are usually between 60 and 70%. So they're not the greatest, and similar with the CHAD 65. So that was why we ended up choosing the CHAD 65. In terms of the no oral anticoagulation arm, because of that issue of equipoise, where we're not really sure if individuals should be anticoagulated or not, we thought it was important for that arm to be included in a trial. And I remember when I was speaking at one of the ASNs to some of the investigators from Renal AF, they were telling me that perhaps some of the recruitment challenges they were having was because of this issue of equipoise not being part of their trial. And they encouraged us when we do ours to really include a no oral anticoagulation arm. In terms of the open label aspect of the trial, we did it primarily for practical purposes. It was an investigator-funded trial, and to get placebo would just be too much of a cost. And also just for the practicality of it, we thought that an open label trial will allow us to assess feasibility in terms of would patients want to participate in the study, and would clinicians want their eligible patients to be recruited. And we thought those were probably the largest barriers rather than blinding in the trial.
As a pilot study, this was, in fact, feasibility was your primary outcome, feasibility, and I think secondarily adherence. So cutting to the chase, you did find that it was feasible to recruit participants. I wonder if you could talk a little bit more about that. And then also, what was adherence like? Because that was problematic in prior anticoagulation studies. So could you tell us a little bit more about what you found?
Sure. So in terms of adherence, our adherence goal was that within the overall cohort recruited, that at least 80% of individuals remained in their treatment group at the end of the 6-month study. And what we found was overall there was 83% adherence. If we break that down into the individual groups, within the apixaban group, there was 92% adherence. The no oral anticoagulation group had 87% adherence. And then when we go on to warfarin, there was a drastic fall off, and only 68% of warfarin of individuals randomized to warfarin remained in that treatment arm at the end of the study. And when we tried to look a little bit deeper into this to get some granularity, why individuals had discontinued warfarin, and they didn't discontinue and go to apixaban, they discontinued and didn't take any oral anticoagulation. It seemed that it wasn't because of bleeding events. And again, this was a very short study. It was more due to patient preference and physician preference. Individuals were going for various procedures and they had their warfarin stopped and just never restarted. So it might be, it brought up the issue of warfarin being an acceptable anticoagulant, both for patients and for their clinicians. So that was the adherence aspect. In terms of the recruitment aspect, our target was recruiting our 150 patients to the trial within 2 years. And we started in December 2019, and 3 months later, COVID hit. And, it just threw everything into chaos. And, there's about a 6 to 8 month period where some sites had opened and some sites closed. So there was all that variability. And that's why it took us, 30 months overall to recruit our target population. But when we accounted for the duration when sites had stopped recruiting, we actually recruited well below the 24-month target.
Wow, that's really quite remarkable. given that how many people experienced challenges during COVID. Let's talk a little bit about some of the other outcomes. This was a pilot study, so you weren't powered to detect differences in clinical outcomes. Nonetheless, there are some interesting findings. You talked about bleeding rates. There were 8 participants who had bleeding events. 4 of them were in the warfarin arm, and then 2 each in the apixaban and no anticoagulation arm. 15 of the participants died. 9 of them were in the warfarin arm, 2 in apixaban and 4 in the no anticoagulation arm. And only 1 participant experienced a stroke, I think. So this brings up, I think, a couple of questions. The first is, and this is a question raised by the editorialist. It's a great editorial by Dr. Anne DeVries. Do you think we can justify continued use of warfarin for stroke prevention in atrial fibrillation for these patients? That's the first question.
So I think warfarin is, going to be a remnant of a bygone era. I don't think it has a role anymore in anticoagulation for dialysis recipients. The trial this trial, SAFE-D, demonstrated that, despite having a really good time in the therapeutic range of 58%, which I think was the highest of all the randomized control trials in dialysis recipients, we still had 32% of participants in the warfarin arm stopping their anticoagulation. So that's clearly a signal there that warfarin is not probably an optimal choice here. And we see it in prescribing rates as well, right? Like even a number of years ago, there was a paper by Ciontis which looked at USRDS data and compared apixaban to warfarin in the dialysis population with atrial fibrillation. And what they found is that warfarin prescriptions are dramatically going down and apixaban prescriptions are going up. And clinically, that's what we're seeing as well. And in addition to what you said at the beginning about vascular calcification and calciphylaxis and issues with drug interactions and food interactions, I think that warfarin's not an ideal choice, and it's sort of fallen to the pharmaceutical dustbin.
That's a great way to put it. I'm wondering how your team, hopefully you're planning a follow-on trial, an efficacy trial. I wonder how your team is thinking about the issue of comparator then. Are you thinking a DOAC versus no anticoagulation? The editorialist brings up the issue of, I think, thrombin inhibitors as a potential comparator as well. And I wonder if you could touch on some of those questions.
Yeah, so in terms of a follow-up trial, we're definitely in discussion to do that. And I think it's going to be, for practicality, a DOAC versus placebo or no oral anticoagulation. And the DOAC is going to be apixaban. I think we're pretty set on that. The factor 11 inhibitors are, there are novel agents there that are being tested in clinical trials in the non-dialysis population. I guess about the Oceanic AF trial, which compared apixaban to acidaxanet, which is a direct thrombin inhibitor, and they stopped the trial prematurely because the factor 11 inhibitor compared to apixaban had a higher rate of strokes, and so they stopped that. There are other 11 inhibitors that are being trialed in phase 3 trials of individuals with atrial fibrillation, looking at stroke prevention. Those are ongoing, but they haven't looked at. As far as I know, I don't think they've looked at the dialysis population, and certainly the acidaxanet, we were going to look at a dialysis population in a subsequent study. I'm not sure where that's fallen into, given the results of Oceanic AF.
I was also wanting to get your thoughts on sort of the choice of outcomes. And I wonder if safety and some of the previous anticoagulation studies should prompt us to rethink, the role of anticoagulation in the dialysis population, given the relatively low risk of stroke. And also, trials like COMPASS, which you're probably familiar with, is this very large study in people with chronic vascular disease enriched for people with CKD, although it didn't include dialysis populations, and tested dual blockade with the DOAC and aspirin versus none, and showed that dual therapy reduced composite cardiovascular outcomes. So I guess what I'm asking is the role of anticoagulation or DOACs more than for atrial fibrillation, but for vascular disease? And, is that the right population? And should we think about outcomes beyond stroke prevention for these therapies?
Yeah, that's a great question. And some of the track investigators are, sorry, the COMPASS investigators are doing a trial now in dialysis patients called TRACK, where they're comparing low dose rivaroxaban, and they don't have an aspirin as the comparator group. It's actually a placebo. What's interesting about, and again, I think stroke is a very important outcome that needs to be included as an outcome or as part of a composite for a number of reasons. One is when you speak to patients about what's most important to them and why would they take anticoagulation, all of them a large majority of them say that it's to prevent stroke. And there have been numerous studies that demonstrate that individuals who have atrial fibrillation are willing to take anticoagulation for stroke prevention, even at a higher cost of bleeding. So in terms of patient preference, I think that definitely has to be there. The question of adding a vascular outcome, like cardiovascular mortality, it's difficult to, in a way, it might be difficult to add it as a composite because, especially in the dialysis population, so much of cardiovascular mortality is non-modifiable, right? Like a large amount of it is probably non-modifiable. And I'm not sure that giving an oral anticoagulation is going to change that in such an appreciable degree that it's going to affect things overall. And also the dose that they're going to be using in TRACK, is a much lower dose than the anticoagulation dose for atrial fibrillation would be. So I think that's sort of the difficulty therein in terms of choosing the most appropriate outcome, and the difficulty sort of trying to tease out what's an ideal composite outcome here.
Well, this has been a really thought-provoking conversation. As we sort of come to a close here, I wonder if you have any practical tips, maybe, to how we should approach this question of who to anticoagulate or whether to anticoagulate the dialysis patient with atrial fibrillation. As we await more definitive evidence from these trials, what should the clinician do when they're faced with this question?
That's always difficult. And, I'm asked this all the time, especially after SAFE. And I think in the absence of any definitive literature at the present time, it's really becomes a personalized decision between the patient and their clinician. I think you have to present them with the facts in terms of the potential for a decrease in the risk of stroke, but the increased risk of bleeding, and you have to have an honest conversation with our patients and get their values and their opinions. And at this point in time, I think that's probably the best thing we could do in the absence of further trials that will clarify this. But it's very difficult, and hopefully we can get some clarity in the next few years.
Well, Dr. Harel, I just want to thank you again for sharing your insights with our listeners and congratulate you on a really excellent study. And we look forward to seeing, your next findings. Thanks for joining us.
Thanks so much. Thanks for having me. It was a pleasure.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.